right, everyone. So this is the last lecture of our series in the GI module. And up to this point, we have learned about everything from the mouth to the anus and everything in between. And this lecture is kind of a sum up of two of the more common chief complaints for GI, which are GI bleed and abdominal pain. And I think with this lecture, what we can do is kind of talk a little bit about the approach to each one of these, because there are some specific things that we want to know as clinicians, and then also use it as a way to kind of check ourselves to see if we can recognize certain presentations and locations and try to differentiate from our large differential that we've gained throughout this module. So here are our instructional objectives as usual. And here's what we're going to cover. We're going to start out with GI bleeds. We're going to talk about the difference between upper and lower GI bleeds. We're going to talk about the assessment, how to work them up, and how to treat some of the conditions. We've covered several things up to this point that include GI bleeding. And so this is kind of a summary of the approach to the patient with the GI bleed. We're also going to cover a little bit about abdominal pain, kind of how to approach it, differential, and kind of a quadrant breakdown to kind of help us wrap our heads around all the different things that cause abdominal pain. So first off, we're going to talk about GI bleeding. Now, really important for us to differentiate between an upper GI bleed and a lower GI bleed. That's kind of the first thing we need to do after resuscitating our patient, of course, is try to figure out, does this bleed sound like it's coming from up high or down low? And we have kind of an arbitrary cutoff point. I don't know that it's super important that we remember this, but they love to test on it. The suspensory ligament of Treitz is considered the division point between the upper GI section of the bowel and the lower GI section. And this ligament attaches right at the duodenal flexure. So right at the end of the duodenum. So you can essentially consider the esophagus, the mouth, the esophagus, the stomach, and the duodenum as part of the upper GI bleed, if there is bleeding to be had from that. And the lower GI bleed is essentially the rest of the small intestine and the entire colon rectal area. That's easy enough, isn't it? I think so. Now, epidemiologically speaking, upper GI bleeds, we're going to see about 100 per 100,000 adults. It is twice as common in men as it is in women. And the older we get, the higher we have the risk of having a GI bleed. And that's in both upper and lower GI bleeds. We talk about lower incidence, about 20 per 100,000. So you can see it's more common to have a upper GI bleeding than lower. And it increases with age, just like I said earlier. And it's, again, somewhat more common in men. Men, you're out of luck. Some of the risk factors for GI bleeding are including things that we've talked about up to this point. So having H. pylori puts you at higher risk of having gastric and duodenal ulcers, peptic ulcer disease, which would put you at a higher risk of getting a GI bleed. That would be considered an upper GI bleed. Taking NSAIDs also puts you at risk of having these ulcers, and that would also be a risk factor for an upper GI bleed. Alcohol use across the board, we said that it can kind of cause some inflammation, some gastritis, potentially contribute to the formation of peptic ulcer disease, and it can also cause other things like Mallory-Weiss tears with binge drinking, and it can even provoke esophageal varices. So alcohol is multifactorial risk factor wise. Cirrhosis, again, that's kind of where alcohol leads you to. If you drink enough of it, cirrhosis is going to put us at higher risk for varicosities, so esophageal varices and gastropathies, and so that is another risk factor. And then we have, vascular disease. Vascular disease can cause things like ischemic bowel, and that can also cause GI bleeding. So I really, really like this image. I did a Google image search. We're lucky that we have Google. It kind of shows kind of in one shot most of the things that we think of when we're talking about GI bleeding. So for upper GI, we have Mallory-Weiss tears, esophageal varices, some gastritis, gastric ulcers, duodenal ulcers, and then moving into more of the lower GI, which would be these. We have ischemic bowel disease. We have intussusception in kids. We have the Meckel's diverticulum, which are both usually in kids. Then we have lower intestinal bleeding, so angiodysplasias, cancers, IBD, diverticulosis, hemorrhoids, and anal fissures. So I thought that was kind of cool to kind of get it all in one action shot. Now, of course, I'm going to have dedicated slides to the different causes of upper GI bleeding first. So I kind of try to think about it, kind of put them in their little boxes for esophagus, stomach, and duodenum. So for the esophagus, with things that we've talked about up to this point already, esophageal varices, those can usually cause about 10% of upper GI bleeding, but they can be very aggressive bleeders, and so we have to be very precautionary when it comes to esophageal varices. Esophagitis, like infection or inflammation caused, by some of the things that we talked about in our first lecture, those can cause bleeding. Esophageal cancer can also erode into a vessel and cause bleeding. Mallory-Weiss tears can cause bleeding, like we've talked about. Stomach. Moving on to the stomach, so gastric ulcers and erosive gastritis are two of the more common etiologies of upper GI bleeding. There's some other things listed on here that are a lot less common. So because of cirrhosis, you can get portal hypertensive gastropathies, a Delafoy lesion, angiodysplasia, and the Gave syndrome that you see here. But by far more commonly, we're going to see gastric ulcers and gastritis. And then what I have statistic-wise, about 20%, 25% erosive gastritis, and about 20% gastric ulcers. And then moving on to the duodenum, duodenal ulcers are going to be, again, about 25% of cases. So those are going to be the more common. I highlighted the three more common ones in red for you. And then we have some angiodysplasia and aortoenteric fistula, which is super rare. But it's kind of a nice rounded out differential for your upper GI bleeding. Then we move on to lower GI bleeding. There's more different etiologies that we can see here. Diverticulosis is going to be the majority of cases. It's most common source of lower GI bleeding, especially in patients over 60 years of age. If you have a patient that is older, more than likely it's going to be diverticulosis. However, one pearl, which I will reiterate a little further on in this lecture, is that pretty much anyone that is elderly that has a lower GI bleed should be ruled out for cancer. Okay, it has to be ruled out. Like we mentioned in our one of our colon lectures, diverticulosis is generally painless, and it can cause anywhere from a little bit of blood to a whole lot of blood and hemodynamic instability. Diverticulitis doesn't bleed nearly as much as osis, but when there's pockets there is potential for bleeding. And then we also mentioned Meckel's causing painless GI bleeding in younger population. Now, there are such things as angiodysplasia. It's, when the vessels themselves are just dysplastic, they're not formed correctly. And that can cause, it's actually pretty common in elderly population as well, although I don't really see many questions on this in Q-banks, but it's good to know that it exists. Ischemia, so mesenteric ischemia, ischemic colitis can both cause bleeding, especially in the later stages once the bowel starts kind of sloughing and becoming necrotic. Hemorrhoids are a big time lower GI bleed cause. Certainly don't want to chalk lower bleeding up to hemorrhoids without looking and doing a little bit more comprehensive investigation. Although if you see the hemorrhoid and you can actually see it bleeding and the blood is just kind of on the paper when they wipe, then you can think it could possibly be hemorrhoids. Trauma related anal fissures can also cause bleeding. Now, I've never seen an anal fissure cause significant hematochezia. It's usually, again, kind of a little bit of blood on the stool or in the bowl or on the paper, not mixed in with the stool. Of course, cancers are on our list for lower GI bleeds. Inflammatory disease like infectious colitis, any type of those enteroinvasive bugs can cause it. And then IBD, of course, ulcerative colitis more so than Crohn's, but both can cause GI bleeding. Iatrogenic, so after biopsies, polypectomies, radiation, And then we mentioned fistulas, which are super rare. And small intestinal bleeding is hard to diagnose in some cases because, as we know, we have our endoscopy, which is another word for scope, right? And we have an upper endoscopy and a lower endoscopy, which we name for the upper endoscopy EGD for short, and the lower endoscopy is going to be colonoscopy. Now, we mentioned that EGD gets all the way up to the first part of the duodenum or second part of the duodenum. But doesn't really go farther than that. Doesn't really get into the large portion of the small bowel. And then colonoscopies can only kind of peek their head up into the terminal ileum. So as you might know from that, there is a section of small intestine, mainly the jejunal and ileum, that cannot be viewed with endoscopy. And in those cases, we have to do other things like pill endoscopy, or other things that we'll talk about later in this lecture. But just mentioning, like, we're going to talk a lot about EGDs and colonoscopies during this lecture, but there is a section of bowel that is not covered by those. So just wanted to remind us. All right, so let's talk about some vocabulary, different terms that come up when we talk about GI bleeding, just to kind of refresh ourselves. First of all, hematemesis is vomiting up blood, and hematemesis is going to suggest upper GI bleeding. I've never seen a lower GI bleed present as hematemesis. It just doesn't work that way. Bleeding proximal to the ligament of Treitz, again there in the portion of the duodenum, it can cause hematemesis, and it can be anywhere from a little bit of blood to severe, bleeding, and it can be ongoing. Coffee ground emesis, on the other hand, also suggests an upper GI bleed, but it usually suggests a lower rate of bleeding. It is what it says it is. It looks like coffee, like ground coffee. And usually it's a slower rate of bleeding, and the blood kind of accumulates and becomes oxidized, and that's what produces that coffee ground appearance. So a lot of times we'll see coffee ground emesis associated with peptic ulcer disease. Melena is going to be black tarry stool. It's usually very foul smelling and sometimes can be liquidy. Essentially what happens is the hemoglobin gets degraded by bacteria in the colon as the stool is making its way down from the upper GI tract to the lower. And so that blood has been in the GI tract for several hours, and the further the bleeding site is away from the rectum, the more likely that it will be melanotic. And the dark stools are coming from an upper GI bleed, generally speaking. 90% of the time is the statistic that I have for you here. Now, one thing to note is that not everything that is dark or black stool is blood. So if in someone that you see a dark stool that is stable, one of the first things that you want to do is confirm that that is in fact blood that you see. So it is a good idea to get either a fecal occult blood test or FIT or whatever you have there locally in your office. Other things that can cause black colored stools would be bismuth, so Pepto-Bismol, iron. When you're taking iron supplementation, that can cause dark, kind of more dense stool. Spinach, charcoal, and licorice can all kind of stain the stool black as well. So good to know. Occasionally, so we said 90% of the time when we see melena, it's suggesting an upper GI bleed. Occasionally, the small bowel can cause melena, but it is very, very unusual for that to be caused by a colonic lesion. Hematochezia is bright red blood per rectum, also abbreviated BRBPR, bright red blood per rectum. This usually represents a lower GI bleed. And if it's really bright red, it's going to typically be kind of the left colon or the rectum. A lot of times if it starts more on the ascending or transverse colon, it'll appear more maroon in color, not black, but more maroon in color. When you see this hematochezia, you should consider things that we talked about in our differential, so diverticulosis, AV malformations, hemorrhoids, colon cancer. There is an exception to this, sometimes with very brisk upper GI bleeds, like for instance, really crazy esophageal variceal bleeds. When it's so brisk, it can actually kind of make its way down the GI tract really, really quickly, and that can kind of avoid being turned into melena, and it can be from an upper GI source. But this is really rare, and these patients typically don't do very well if the upper GI bleed is coming out as bright red blood for rectum. One other thing to mention here is occult blood. So sometimes when patients have GI issues for whatever abdominal pain or anemia or things, we will do a test looking for blood in the stool. And this is when we don't see it with our naked eye. It looks like normal stool. And so occult blood means that we don't see it, but it's there. And occult blood in the stool can be from anywhere in the GI tract. And it typically warrants more of a workup. Now, other things that you want to look for as far as clinical features of GI bleeding, we're losing volume. We're using intravascular volume through blood, through the form of blood. And so depending on how quickly or briskly the bleed is happening or how long the patient has had the bleed, we might see in patients signs or symptoms of volume depletion. So dizziness, nausea, lightheadedness, kind of vasovagal kind of stuff, changing with position. So, getting tachycardic when we sit up or losing blood pressure, bottoming out. Other things that we can see if we're losing blood, especially slower bleeds over long periods of time, we can see signs of anemia. All right. So I included a couple pictures here. They're from the previous slide, but this was a better place to put them. This here is melena, black, kind of looks like tar on the road. And this here is a sample of hematochezia. Now this is a more significant hematochezia. You can see that the blood is kind of pooled. And it looks like it's kind of mixed within and it's all over the stool. So this is pretty significant. Definitely not something I would expect to see, for instance, with a hemorrhoid or an anal fissure. So that can kind of aid you in your diagnosis. Now, patients with occult bleeding and even with small GI bleeds besides the blood itself, they could be asymptomatic. Symptoms of anemia, like we talked about before, can be fatigue, weakness, kind of generalized not wellness, dyspnea if they're losing significant amount of RBCs, pallor, lightheadedness, and even passing out. Other clinical manifestations of GI bleeding, depending on what the etiology is abdominal pain, heartburn, for instance, for ulcers or gastritis. Anytime we see the weight loss associated, we would think malignancy first. And then always make it a point of asking for those with GI bleeds, what medications the patient's on, especially looking for things like NSAIDs, aspirin, or blood thinners, that kind of stuff. And then just a quick recap: coffee ground emesis, upper GI bleed; hematemesis, upper GI bleed; melena, upper GI bleed, but coming out the other end; and hematochezia, lower GI bleed, usually. So in physical exam, patients with mild or occult bleeding, they might not have any significant findings on physical exam other than the blood in the stool. One of the things we need to assess for really quickly in a patient with GI bleeding, whether it be upper or lower, is evidence of hemodynamic instability. Hemodynamic instability is going to be, dizziness, especially with change in position, so positional dizziness, tachycardia, hypotension, someone that's altered, because remember, we're losing blood. Blood is intravascular volume. When we lose intravascular volume, we change positions, gravity brings the blood down, pulls it away from the brain, and these patients can get presyncopal or even have syncope related to it. And this is essentially what we're looking for, is this orthostatic hypotension. And we can take special vital signs for this. We're looking for pale skin color, conjunctiva. Sometimes the first place that we notice pallor is in the conjunctiva, so we can kind of pull down the lower eyelid and look there. That's a good place to kind of start assessing. Like we said before, some patients might have that abdominal tenderness depending on the etiology. We always want to perform a rectal examination, at least at the very least with our eyes. We're looking for the color of the stool, any anal lesions. Even if the stool is not bloody, we would take a sample to look for blood, occult blood in the stool. Hemorrhoids, we're looking for anal fissures, masses, And then, of course, in physical exam, we also want to look for signs of chronic liver failure, such as the gynecomastia, spider angiomata, splenomegaly, asterixis from hepatic encephalopathy, ascites, distension, that kind of stuff. And again, like I mentioned before, a nice pearl to remember is that if a lower GI bleed or even a positive occult blood test in the stool in a patient over 40 is colon cancer until proven otherwise. Very, very important to rule out cancer in these patients. Now, I was watching an osmosis lecture. I really like osmosis. And looking at this orthostatic hypotension or hemodynamic instability, I thought it was nice that they kind of like laid this out for you, kind of the progression of hemodynamic instability. So those with mild hypovolemia, so only losing less than 15% of their volume, will show initially kind of a resting tachycardia. In moderate, when you're losing anywhere from 15 to 40% of your volume, you're going to start getting that orthostatic hypotension. And that's when you take the blood pressure and pulse laying, and then you have the patient sit up and you repeat that, and usually we'll see a drop of greater than 20 millimeters of mercury in the systolic blood pressure. And then severe is going to be, hypotension, tachycardia, the whole nine yards. Another kind of chart or algorithm, kind of flow chart that I liked, I kind of took 3 individual charts and kind of added to it because I liked it, was kind of the approach to the GI bleed. And this is one, kind of a simple one to think about. And then I have some more that are tailored and specific for upper and lower GI bleed that we'll go through a little later. So the first thing that you want to assess in someone with a GI bleed is your patient hemodynamically stable or not? Okay, that's super important. If the patient is unstable, vital signs are off, they might be incoherent or something's off, you need to have vigorous IV resuscitation. And these patients get 2 large bore IVs. They get lots of IV fluids in a bolus form. And then we also will check, cross-match their blood so that we can give them blood products if needed. And then we reassess. And if they are still unstable, you consider trying to find a source. If they're stable, then you can proceed managing kind of along this pathway. Now, if the patient is hemodynamically stable initially, you want to assess whether you think that the bleed is an upper or a lower GI bleed. If we think it is an upper GI bleed, we'll see these things, usually either hematemesis, coffee ground emesis, or melena. Occult blood, can't really tell whether it's upper or lower. So with upper GI bleed, the first thing that you're going to want to do after they are stabilized, or if they are stable, is to do an EGD. EGD is going to be the best test to try to localize the source of the bleed, and in most cases it's pretty accurate. If we can't find it, then usually we follow up with a colonoscopy, and if we can't find it still after that, then we consider evaluating the small bowel. Now, if we think initially that they have some hematochezia, kind of weight loss or occult blood, then we can go more down the lower GI pathway. And in that case, colonoscopy is generally done within the first 24 hours. And a lot of times with these EGDs are also done to look for the potential upper GI bleed. All right, so other laboratories that we're thinking of. CBC, really important, right? We use that to assess for anemia. Now, keep in mind that the hemoglobin and hematocrit level might initially be normal in acute bleeds. And that's because, we're seeing them losing whole blood. They're not losing just part of the blood. They're losing the whole blood. And it isn't until we start replacing the intravascular volume with normal saline that the blood starts becoming diluted and we start seeing a decrease in the hemoglobin and hematocrit. So what is an abnormal hemoglobin? Well, usually a transfusible hemoglobin in a young healthy patient is 7. It's kind of the given number. It can be anywhere from 7 to 8. But in elderly patients and those with cardiac disease or significant comorbidities, hemoglobin that is transfusible is usually anywhere from 9 to 10. So we have a lower threshold for transfusing those patients. Other things we're looking for, if we think there's a GI bleed, so a fecal cold blood test or a stool guaiac that we can do at bedside. Coagulation factors, looking for coagulopathies that might be initiating the GI bleed. LFTs, we're looking for liver disease. Metabolic panel, we're looking for a BUN, an increased BUN from baseline, or even an increased BUN to creatinine ratio is consistent with an upper GI bleed, so we do look at that in patients that do not have existing renal insufficiency. The higher the ratio, the more likely that the bleed is coming from the upper GI area. We also want to check renal function. A lot of times we will do iron studies looking for kind of a longer term iron deficiency anemia. Cross matching for blood and transfusions. We said we would do that, especially early on. And if you suspect lower GI bleeding, we still need to exclude upper GI bleeding before attempting to localize. So many times they will have an upper endoscopy and a lower endoscopy. Imaging wise, CTAs are pretty good. They can detect a little bleed, and they use IV contrast to do that. There's also kind of radionucleotide imaging where we can kind of tag for the blood to look for blood loss or sites of extravasation. That is considered technically the most sensitive radiographic test for bleeds. But just by and far, we do the scopes first. So other things, kind of procedures associated with GI bleeding. So NG tubes, we've talked about those before. These procedures are usually done initially. They help determine whether a GI bleed is in fact coming from an upper GI source. And we also use it to kind of help empty the stomach so that the blood is not coming up and the patient's aspirating. We can also use it to kind of clear out the upper GI tract if a patient is going to go for an endoscopy to help have a better view. Let's see what's next. So upper endoscopy, like we said, is the modality of choice for an upper GI bleed. It's great because you can usually find the hemorrhage site anywhere from the esophagus down to the duodenum, and at that point you can both diagnose and potentially treat these bleeders. And most patients with upper GI bleeding that can tolerate have an endoscopy within 24 hours. Lower GI bleeding, again, it's pretty straightforward. Colonoscopy is the modality of choice. Again, you'll be able to visualize the hemorrhage and also potentially treat the hemorrhage. The only thing with a colonoscopy is that a prep is required, so we do have to clean out the bowel before we are able to visualize anything via colonoscopy. And usually most patients with lower GI bleeding have the upper endoscopy also within 24 hours. Now, for the parts of the small intestine that are not able to be viewed with EGD and colonoscopy and not able to determine where the bleed is coming from, a capsule endoscopy can be used. It's kind of like a pill camera that patients ingest. And we just have to be careful in certain patients that we suspect to maybe have strictures because they can get stuck. And if the pill does get stuck, you have to go in and remove it with surgery. There's that GI bleed scan, the radionucleotide scanning. These can detect really, really small blood bleeds. And, you know, it's controversial whether or not an arteriography is needed after this, but it is another tool that we can use to determine where it is. Again, angiography reserved for patients who really cannot tolerate endoscopy. So again, we're going to go through this multiple times. I want to make sure we get it down. Initial steps in any patient with a GI bleeding is resuscitation. Okay, it doesn't matter if they're stable now or not. The GI bleeders can become unstable very, very quickly. So we do have to assess, vital signs, and keep in mind that initially speaking, some vital signs can be normal. Even though there is significant hemorrhage present, our body does a pretty good job of compensating early on. Resuscitation, again, first step. And by resuscitation, I mean IV fluids, potentially a transfusion, hooking them up to the monitor and keeping a close eye on them. we do need to perform rectal examination, testing for stool, especially occult blood. And then be careful, because elderly patients are, we know from what we've just talked about, are the most common set of patients to get these GI bleeds. And because they're older, they are more fragile, so they have the chance of getting MIs just from having this hemodynamic instability. Their body and their system kind of get stressed, and then we can have more than just a GI bleed problem. We can get MIs, so might need to consider thinking about that. Here's some other assessment things we might consider. If a patient is having severe hematemesis, there's a chance of aspiration, so the patient may need to be intubated. Like we mentioned before, we should get IV access. Usually with larger bleeds, we consider 2 large bore peripheral IVs and even a central line. We give IV fluids. We send the blood to screen for their blood type and have blood ready to go, and then we transfuse. So that's resuscitation. So let's talk about treatment. So the good thing with GI bleeds is that in and around 80% of GI bleeds will stop bleeding without intervention. Of all the GI bleeds we have out there, majority of them will stop whether we do anything or not. That's good. However, they're not going to test you on that 80%. They're going to test you on the 20% that you could do something about, okay? If the patient is hemodynamically unstable, always resuscitation. Even if they're not unstable, we still need to consider the ABCs. And then once the patient is stabilized, you can obtain your diagnosis. You'll again want to give supplemental oxygen, place the IVs, consider intubation, give fluids. You'll want to draw lab work, including CBC, including H&H, PT, PTT, and platelets are in the CBC. And you'll want to monitor the hemoglobin. Remember, we said that initially the hemoglobin and hematocrit can be normal for a period of time before you start seeing it drop. You start monitoring, and you keep monitoring every 4 to 8 hours until the hemoglobin is stable for at least 24. Again, we want to cross-match for transfusion. And then medications, we generally, for patients with GI bleeding, especially upper, we tend to give kind of prophylactic PPIs. And then if we have varices, or we're considering varices, we'll give IV octreotide and antibiotics. The rest of the treatment really depends on the cause or the source of the bleed, right? So in upper GI bleeding, you can do an EGD, you can coagulate the bleeding vessel, inject epinephrine, or even do some thermal hemostasis or electrocoagulation. There's also clips that can be placed. And then, of course, last resort would be surgery. And then lower GI bleeding, we start with colonoscopy. We can take out polyps, we can do injections, lasers, and cauteries and things to try to stop the bleeding that way. Other treatments, so angiography, you can give, remember those are invasive procedures. We can fix embolizations, vasoconstriction, we can do that. And then there's also balloon tamponade. So remember we talked about in esophageal varices, as a temporary means of kind of stopping or tamponading the blood, you can use these balloons. You'll want to intubate the patient first, and then a tube is inserted into the esophagus, and they inflate the balloon to kind of stop the bleeding. Of course, this is only temporary, and this is just to kind of stop the bleeding long enough for you to get a plan going and get hemostasis and generate a plan for more permanent hemostasis. Okay, surgery is considered when the bleeding cannot be contained through all of the above interventions, which is pretty rare. We're usually pretty good at stopping those bleedings with what we have available to us. And then here's some other reasons, kind of why, or indications for surgery. Some factors that might increase the mortality in GI bleeding, of course, age. So anyone greater than the age of 65 has increased mortality with GI bleeding. The severity of the initial bleed, whether or not they have comorbidities, recurrence of bleeding while in the hospital, need for surgery, significant transfusion amounts. Of course, esophageal varices, they have up to a 30% mortality rate. And also, if they go in and they see, recent hemorrhages, there has an increased mortality rate. All these things are pretty common sense, right? So it's not something I think you need to memorize, but I think you should definitely have a heightened sense of urgency when you have patients that fall in these criteria. So I did promise you a couple algorithms. These are from Up to Date. I love algorithms. They help me kind of think logically from step A to step Z with my patient or with my hypothetical patient. This is the upper GI bleed algorithm. We have a patient that presents with either hematemesis or melena. And the first thing, again, that we have to assess is hemodynamic instability. If they are hemodynamically stable, we do the upper endoscopy, and that's usually done within the first 24 hours. If we identify the source, yes, we treat it. If we don't, we consider getting a colonoscopy. And then if we can't find the source that way, we go for small bowel evaluation. Okay, so that's if they are stable. If they're unstable, the first thing is going to be resuscitate. Prepare for emergency endoscopy, get surgery on board, IRs on board. Everybody's prepared for the worst. We get the upper endoscopy as soon as the patient becomes stable. If we can find the source, we treat it. If we can't, we decide whether or not we need a colonoscopy. If we can find it, we treat it. If we can't, then we consider some of the other options, looking for a source, and then it gets more and more specific, getting down this pathway. Okay. This is the algorithm for patients with hematochezia. Now, this is excluding those with minimal rectal bleeding. So if you just have a little bit of a tiny streak when you wipe on your paper, this is not the algorithm for you, okay? But for frank hematochezia, the first thing we want to assess is hemodynamic stability. If our patient's stable, we do a colonoscopy. If the source is found, we treat it. If it's not, we have to consider other things, including upper endoscopy and then small bowel. For hematochezia with a hemodynamically unstable patient, we of course need to resuscitate, consider consulting surgery and IR and getting everybody on board. We do an upper endoscopy. If we can't find the source, then we move on. We can do colonoscopies, angiographies, etc. So we just kind of keep moving down the algorithm. And that's my take on upper and lower GI bleeding. Paul Bolin has a really good lecture on GI bleeding that I like to watch. I think it's good. It has some little cases in there and stuff. So if you have extra time, head on over to YouTube and take a peek at that. Moving on, we're going to talk about abdominal pain. So let's get into it. I like this little image here. It's kind of like my GI bleed image. It has kind of like all the little things that you can think of that could cause pain. And I'll tell you this, abdominal pain is huge, right? It's probably the number one reason why patients come to the ER. It's also a very common outpatient chief complaint, and it can be caused by so many different things. And that's why it makes it challenging to assess a patient with abdominal pain. It's very common. It's both outpatient and inpatient. And like we said, it can be very challenging to diagnose. It can represent a spectrum of diseases, like we said before. And these are from anywhere from things that are benign and self-limited to surgical emergencies. So that's why it's so important that we know our differentials and we know what to look for. We have to take an approach that assesses many factors, including how likely the disease is to happen, what the patient is presenting wise in their history, how our physical exam is leading us, our laboratory tests, of course, and imaging studies. One of the first steps we need to determine is whether the pain is acute or chronic, where the pain is locating, and then from there can kind of guide our evaluation. So acute versus chronic. Let's talk a little bit about chronic abdominal pain. So we've learned a lot of different things throughout this module that can cause a chronic abdominal pain. Now, even in patients with a chronic abdominal pain, there can be kind of an acute on chronic presentation where we get a more acute picture, but then we start digging a little deeper and we find that there's some underlying disease that's causing the acute exacerbation. And so when we classify kind of more of a chronic abdominal pain, upper GI wise, we're thinking things like peptic ulcer disease, dyspepsia, reflux, biliary colic, pancreatitis, cancer, in multiple places, IBS and celiac, kind of our chronic upper abdominal pain list. And then the lower can be, again, IBS, diverticulitis, lactose intolerance, dysmenorrhea, which is not a GI complaint, but can be, there's some GU or female woman type thing, chronic pelvic pain. We got some hernias on here, IBD, and cancer. This is my acute abdominal pain by location, kind of. It's not all inclusive, but it has some of the more common presentations or the more common diagnoses depending on where the pain is presenting. So one of the first things you need to assess in a patient with abdominal pain is where their pain is located. Some patients literally, you ask them to point with one finger, they'll take their finger and they'll run it in circles all the way around their abdomen. So if you can, best to get them to localize their pain with one finger and leave it there, right? And sometimes it's still hard to get it, but any location, anywhere in the bowel can have these things. They don't really localize. One thing that I didn't mention before, but I should, is looking at the abdominal wall is very important. I don't know how many of you assess your patients with the gown up or not, or how many times you've been to see your practitioner and they just kind of look at you without looking at your skin. But get in the habit of looking at the skin of your patient. When you do an abdominal exam or a back exam, lift up the gown and look at their skin. You're looking for signs and symptoms that you wouldn't find if you don't look yourself. Okay. Right upper quadrant are a lot of the things that we've seen before: biliary stuff, hepatic stuff. You can even have some pulmonary things like pneumonia or embolus. I've seen kids present with right upper quadrant pain that have pneumonia. Colon stuff, we got the colon kind of up that area. It's uncommon that you'd see a diverticulitis in the right upper quadrant, but I guess it could happen. And then renal. So kidney stones can present anywhere. Usually you see kind of a lower quadrant or flank pain, but it can present in any kind of area. Epigastric, again, you're going to see some of the same players: biliary, gastric. Now you see pancreatic, some vascular stuff. Aortic dissection is one of those under differential that you have to make the diagnosis. And then, of course, we include some cardiac stuff here, okay? MIs and things like that we should consider. Right lower quadrant, not everything in the right lower quadrant is appendicitis. But we do tend to think of appendicitis. You can have some diverticulitis even there, IBD, IBS. Gynecologically speaking, anything kind of in the right, left, lower quadrants or suprapubic region in a female can be really tricky because not only do we have GI organs, but we have female organs at play. And so you do have a differential that grows quite a bit more with a female patient than a male. Always important, as we've mentioned previously, to rule out pregnancy. And when I say rule out pregnancy, unless they do not have their pelvic organs, you should definitively rule out pregnancy with at least a urine pregnancy test. And I do that pretty exclusively, urine pregnancy test. You're looking for pregnancy and ectopic pregnancy, which is a true emergency. Moving over to the left side, left upper quadrant is going to be, you can have some cardiac, gastric because your stomach is there, pancreatic, and then some of the vascular stuff can present there as well. Periumbilical is usually a pretty vague pain. It can be kind of that early appendicitis before it migrates to the right lower quadrant. It can be pretty vague, and I find that a lot of kids kind of point to this periumbilical area. They have a little more trouble kind of localizing it. Suprapubic, when I think of suprapubic, I always think of things like UTIs and pelvic issues, but it really can be anything. Again, it's kind of a non-specific area, these two areas right here. And then left lower quadrant, the first thing I think of is diverticulitis, but there's really a myriad of different things that it could be, especially in our female patients. Now, in our male patients, one of the things that we can't forget is growing things. So we should also consider things like testicular torsion and testicular issues in our lower quadrants for man. Now, when evaluating a patient with acute abdominal pain, we have to consider both what is most common things that present with these signs and these symptoms and in these areas. So common things are common. And then we also have to consider the things that are life-threatening, because we cannot miss those things. So those are kind of how we start building our differential diagnosis. The location is going to be crucial. It's going to help drive our evaluation. For instance, a right upper quadrant abdominal pain, I'm usually going to get an ultrasound first, whereas a right lower quadrant abdominal pain in an adult, I'm probably going to get the CT first. Okay, so very important to localize the pain if at all possible. It also depends where you are. You know, if you're in a clinic, you have limited means to do acute testing. So you have to consider, whether you're going to send the patient for imaging and studies, and if it's okay to wait for those results to come back, or if there is enough high acuity to send them to a more urgent or emergent facility, right? So especially with surgical emergencies, those are not things you can sit around and wait for to be done outpatient. So knowing where you are is important. ER versus primary care, a regular clinic, urgent care, GI specialist clinic, and you order kind of those tests based on kind of where you are, right? Many times, and this is very frustrating to patients, we don't always get to the bottom of their pain on the first visit. In the ER, our job is to rule out life-threatening things. And can be very frustrating because a lot of patients want to know exactly what it is. Well, in the ER, our job is not to tell you exactly what it is. It's to rule out the bad things that it isn't, and make the diagnosis if it is. Okay. Also, in outpatient, the initial visit is usually going to be kind of to assess the situation, figure out whether they need a referral, whether they need laboratories or imaging or things like that. So it can take several visits to get to the bottom of the cause of the abdominal pain. Sometimes we have to refer for surgery. Sometimes we have to refer to GI. And so it's important to know that we're not always going to figure things out right away. Other things like we mentioned before, abdominal wall, we can't forget those things, such as shingles. Shingles can cause pretty significant burning pain, and they're often misdiagnosed because we don't take enough time with our patients and we don't look at their skin. Physical exam wise, we want to, of course, the first thing I do when I walk in a room with a patient is I'm looking at their general appearance. Are they laying in bed quietly? Are they writhing in pain? Are they restless? Are they on their phone? Are they eating Cheetos? And what are they doing, right? And before even I walk in the room, I'm looking at their chief complaint and I'm looking at their vital signs. It's going to give me a good picture of how ill this patient is. That's before I walk in, and I'm already brainstorming. I have a clinician's brain. It's like an investigator, right, or a detective. You're always trying to get to the bottom of it, thinking of things that it could possibly be. Patients with peritoneal signs or peritonitis, they tend to lie very still, whereas even if you just bump their bed when you walk in, they will writhe in pain. Whereas patients that have like renal colic from like a kidney stone, they tend to be more able to sit still. They're very restless and they're kind of writhing back and forth, uncomfortable. Fever, of course, we're looking for that. It suggests an infection. Although if a patient doesn't have fever, it doesn't mean they don't have an infection. Those that are older and immunocompromised tend to mount a less obvious response to these type of infections. We're looking for things like tachycardia and orthostatic hypotension to suggest hypovolemia. Remember, the location of the pain is going to kind of drive the remainder of the exam. Don't neglect your cardio and your pulm exams because upper GI pain can kind of overlap. And then, of course, depending on where your pain is located, there are special tests that we can do. For instance, in the right upper quadrant, we can do a Murphy's sign looking for, cholecystitis. In the right lower quadrant, we can do, Psoas sign, or we can check a Rovsing sign, things like that. And then, of course, we always want to assess for rebound tenderness and guarding to suggest peritonitis. It's arguable that any patient that comes in with abdominal pain should have a rectal examination. And any female that comes in with lower abdominal pain should have a pelvic evaluation, at the very least a bimanual exam. When I work in the ER, any female that comes in with a lower abdominal or pelvic pain gets a pelvic examination. And in those, because the lower abdominal and the pelvic regions overlap with each other, you can miss a diagnosis that way. When we do a pelvic examination, you'll get to this when you do your women's health module. But what we're looking for is, discharge, signs of an infection, cervical motion tenderness, looking fullness in the adnexa, looking for ectopic pregnancies, tubo-ovarian abscesses, or ovarian torsions. Laboratory tests. We've talked about lab tests for abdominal pain pretty much throughout this entire module. We tend to do kind of our old faithfuls. We get CBC. We usually tend to get an amylase and lipase. If we're going to have to pick one, lipase is the better one to get, looking for pancreatitis. We also want to get either a CMP or a BMP with liver enzymes. I usually go for the CMP. It gives me a lot of quick information. We get UA, and if they're women in childbearing years, urine pregnancy test. And then plus or minus some of the other things. If they have lower pelvic pain, you might want to consider testing for STIs like gonorrhea and chlamydia. If you have bleeding associated, you might consider getting PT and PTT. If they have signs or symptoms of inflammatory bowel disease or things like that, you might need to get some stool studies or ESR, CRP, things like that. Imaging studies. Imaging is very crucial in abdominal pain. We do a lot of imaging. There are clinical diagnoses to be made, but the majority of the time we get imaging, okay? And it really just based on where the pain is and what we think it could be. So again, like we've mentioned before, ultrasound is going to be the radiologic imaging study of choice for right upper quadrant pain. CT, across the board, we do it a lot, especially in the emergency department, for patients with kind of non-specific pain or pain that we think is right lower quadrant, for instance, appendicitis, diverticulitis, and then pretty much anything else that we can think of that we can't quite put our finger on, and the patient looks really ill, we tend to get CTs. And this is usually with IV contrast, at least sometimes oral as well. Now, if we're considering that it could be a kidney stone, for instance, instead of something intra-abdominal or intracolonic, right, then we would do the CT without contrast. That's the best test to do it for kidney stone. The left upper quadrant is kind of this no man's land. It's kind of hard to decide what imaging to get for left upper quadrant. If you're thinking could be some sort of peptic ulcer disease or things, we would first, of course, if they have peritoneal signs, get upright films to look for free air under the diaphragm. But otherwise, if the patient's not too ill, we tend to refer them for an outpatient endoscopy. Sometimes they get ultrasounds, sometimes they get CTs. It's kind of hard to tell with that. So I can't really help you too much on left upper quadrant. It's kind of a case-by-case basis. Again, plain radiography does have a place in the workup of abdominal pain. It's not the best, and it's not great at making the diagnosis, but it can be really, really helpful tool in quickly assessing a patient's status. It's certainly less expensive, and it's less radiation than a CT, although it's not always good. A lot of times you're going to have to get something else in addition to it. The best place that I see this utilized is, one, if you're considering that the patient could have free air, a perfed viscus of the GI tract. This is the quickest and most efficient test to look for free under the diaphragm. Other things that can see really well are small bowel obstructions, air fluid levels, things like that. That can help. You can see calcifications, but I would not rely on plain imaging to diagnose gallstones, kidney stones, appendiculitis, none of that. I wouldn't. And then we have women. Women are, like I said, women are special, especially in childbearing age. If we're considering something gynecologic, if it's lower, sometimes it can be hard to decide whether to start with the CT or start with an ultrasound, and we usually do a transvaginal ultrasonography for the pelvic region. Now, if they're pregnant, for sure, we're going for the ultrasound. But if they're not pregnant, then it's kind of a judgment call. You do the pelvic exam and try to decide, is it more pelvic, more abdominal, and then kind of go from there. Sometimes you have to end up getting both. Ectopic pregnancy, again, transvaginal ultrasonography is going to be the best. All right, so again, some special populations. We talked about them already a little bit. Women in childbearing age, first thing we got to do, of course, after we assess their status, they get their vital signs, everything, is to do a pregnancy test. If it's positive, we're going to do a transvaginal ultrasound looking for ectopic pregnancy. It is an ectopic pregnancy until proven otherwise for abdominal pain and a positive pregnancy test. And then if it's negative, you have to decide whether it's a genitourinary issue or an abdominal issue. And then from there, it takes some experience, and sometimes you don't get it right. You have to do both, right? I've had patients before that I could have sworn were appendicitis, fever, right lower quadrant pain, and I get the CT and it sees a mass in the ovarian, in the fallopian tube. Then you get the ultrasound and it shows a tube ovarian abscess. So you kind of have to. Sometimes you're not always 100%, and things can overlap. Older folks, you have to be more cautious. Consider other things, urinary tract infections. But most of them require, especially older patients, require more of a workup. You don't want to just chalk it up to constipation or something like that. You got to kind of look a little more. All right, so again, this is kind of what we just talked about. And then last but not least, there's this quick kind of at a glance look, again, at how to assess for abdominal pain. By no means is this all inclusive. You have to use your brain as a clinician, and we've put all these differentials up in your brain. We've taught you what the typical presentations are for these things, and so then it is up to you to use your patient encounter skills to get that history, to get good physical exam findings, and then use your ICM brain to decide, I think this is my differential, this is what I need to do to rule these things in or out, this is how I'm going to treat my patient. And so I like this because it kind of helps you kind of work your way through abdominal pain in a very at a glance kind of bird's eye view approach. I hope this was helpful. I know that abdominal pain and GI bleeding can be a little bit daunting, but that's the purpose. That's the purpose of our module, is to give you those presentations, those signs and symptoms, and give you the tools you need to kind of start forming those differentials and using your skills as a clinician to put the pieces together and to come up with the right diagnosis and rule out the bad things, okay? So, like again, I said, I hope that this lecture was helpful, and we will see you in class.